Alright.
Hi, folks. This is John Adamson, the Rehab and Documentation Guru, and today I have Frank Aviles on the phone with me. Hi, Frank.
Hello, John. How are you?
I'm good, thank you. I want to give our viewers a little bit of background about you before we get started and why I have you on the call today. So Frank is a PT. He also has his certified wound specialty. He's also a fellow of the, I forget what all those initials stand for, but let's just say he's done a lot of training in wound care. He's a certified lymph therapist. He's also a trainer in wound care and edema management with lymph management. And just to give you a little bit of background about what this guy does also, he's a wound care service line director at Natchitoches Hospital. Did I say that right? All right. It doesn't
That's correct.
Anything like it's spelled. He is the owner, wound care consultant, and speaker, PT, and lymphedema therapist for Cane River Therapy Services, LLC. He is an editorial board member for Today's Wound Clinic. He's on the educating steering committee for the Association for Advancement for Wound Care, and he is the practice chair for wound management section for the American Physical Therapy Association. So at this point, Frank, the big question everybody else has that's watching this is, when do you sleep?
I don't. Sleep is overrated in a way.
Yeah.
But I just love what I do.
Well, I could tell that. Well, and that's why I have you on, because you are a recognized industry expert in this particular area. And so I have some questions for you, because one of the things that I've found going across the nation and speaking to thousands of therapists about documentation is that the majority, and I'm talking about the vast majority of them, have no idea about wound care. And I believe this is a hugely untapped area for therapists to get involved in. So the first thing I'd like to ask you to speak a little bit about from your passion that you have is, tell therapists that are watching this video why they should consider getting some kind of advanced training in wound care.
I sure will, John. And actually, I want to add a little more to the story. As you said, I'm very passionate about this. And talking to clinicians all over the country, we did say we love wound care, but the problem is we're going to promote wound care, but there's no therapists out there that are willing to do wound care. So in order to change this, I've been involved in a project. It's been probably a 6-year project where we're actually going to, in June, we're going to the House of Delegates to actually have our own certification for the American Physical Therapy Association for the wound care section. So we're trying to change that. So in order for therapists, I would highly recommend to go get a certification in wound care, because it will increase your skills, your knowledge. Okay? In addition to that, you're going to be able to demonstrate competency, and also you will learn about best practices out there. Wound care changes to me just about every other day. And in order for you to treat the patient properly and get reimbursed for what you do, you have to know what you're talking about. And when you do all that together, you have a zero patient harm environment.
You know, you brought up a good point about zero patient harm. One of the things I talk about in my course is the fact that we really, if we're talking about documenting the skills that we're doing and picking up patients for medically necessary care, one of the things we have to keep in mind is that we should first do no harm. And so having subject matter expertise in the areas that we're treating is vitally important. So I'm glad you spoke to that, because that was not one of the questions I said to you, but you brought up a really good point. Now, Frank.
And actually, John, I'm going to ask you something else. You know, I teach, I'm involved with a lot of pressure injury or ulcer prevention at a hospital. And, you know, I always ask people, we talk about avoidable and unavoidable. And I ask them, what is the difference? And many people can't tell me the answer. But the answer that I see out there all over the country is that the difference between avoidable and unavoidable is that whether we documented that we did what we said we were going to do, and we failed to document properly when it comes to having documentation on pressure ulcers or injuries.
And so would that be the correct answer?
The correct answer is documenting that you
Document.
did everything you said you were going to do, or
Right.
document that you follow your policies.
Right. Oh, very good. Very good. That's a good point because nobody likes preventable wounds to occur. That's for sure.
Mhm.
Now, one of the things I've seen, Frank, is that, again, universally, I haven't met many therapists that actually do wound care, but you being in this industry, do you see therapists pretty much in all practice settings from post-acute care on getting involved in wound care?
I do. I think that the interest is out there. The problem is, are we educating the therapist to have the right tools to be in those settings? And all over the country, there's a lot of therapists involved in wound care. I've seen them in acute care. Of course, in acute care, we get involved with the traumas, the post-surgicals, the infections. We're also doing preventative. We're also maybe treating along nursing. The models that work really best is those that are collaborative, where you have a team of people working together and everybody knowing their roles. From there, it can transition to the outpatient world. And the outpatient, they're more stable, but they're complex because now you have to control a lot of the environment. If they have to be offloaded, you have to be a great educator because if they don't understand why they're coming to see you, they're not going to get better. So as you move on to the skilled nursing facility, they're a little more complex, a little more frail, but now you're able to do more. You have to not just be preventable, but you have all the tools to help them, whether it's debridement or using the modalities that we have to decrease their chronicity. And then from there, you can have home health as well. Home health, there's more therapists being involved in wound care. I've seen it where the nurse and the therapist have their own roles. But you can see wound care across the gamut. And I'm going to tell you, I see more therapists wanting to get involved. It's just that we may not have the skills or the education to say, here's what I can do for you.
Right, right. I agree. That skill set sometimes is lacking. Give the therapists that are watching this video just a little bit of an overview of what are some of the things a therapist specifically, directly or indirectly, can do to treat wounds.
All right. Well, directly, of course, we can actually be bedside. When the doctor gets us involved with wound care, we have a lot of tools that we can use, whether we're going to, in addition to the assessment, whether we're going to debride. We can use sharp debridement. That's in our Practice Act. But I would highly recommend that you train before you do that. The other things that we can do is, if you have swelling, we're going to be able to put compression on. There's probably about 6 different types of compression that we can apply. We can get involved with edema management through the lymphatics management as well. We have a plethora of tools. We have electrical stimulation. We could use low frequency ultrasound. We can use regular ultrasound. So we have a lot in our tool bag that we can help wounds with. Indirectly, we can also, the way I look at indirectly care is being a consultant, being part of a team that you can share your knowledge with. I work and help oversee a wound care center, and when all the doctors and all the nurses, we all get together, everybody brings a different aspect to the care. You know, usually I'm the one that said, well, how are they walking? You know, why do they have a limp? Why is the range of motion decreased? And a lot of times it could be as simple as that, determining that it may be the culprit for the wound not healing. So you can get involved directly and indirectly. I mean, we can go on about that.
Sure. I mean, that would be a whole nother video right there. Frank, I just want to build off something that you said. While you and I would recognize, for example, the role that ultrasound would play in wound healing, unfortunately at this time, Medicare does not. And so they do not reimburse for ultrasound for the purposes of wounds, unfortunately. And just for my watchers, my viewers, keep in mind that your billing codes for shortwave diathermy and e-stim are different when applied for wound care versus typical e-stim and shortwave diathermy. And that's something you got to keep in mind. I don't know if you want to add anything to that.
Now, it's all based on the setting as well, too, because in an outpatient setting and an inpatient setting is going to vary the utilization of it. And as we spoke a while back, that in order for us to get reimbursed, we have to document really well. We've got to paint the picture in order for somebody to pick up or pay for and say they did the right thing and it's medically necessary.
Right. Absolutely. Yeah, that's key. If it's not on paper, you didn't do it. That's let me ask you something. So you talked a little bit about using physical agent modalities. What are some of the wound characteristics you look for to determine whether a physical agent modality would be useful?
Well, a lot of times I see people struggling with this. I look at it as trying to throw darts at a dartboard and hoping you get the bullseye. So I tried to, and actually 10 years ago, I started trying to figure out, everybody wants cheat sheets in wound care. That's just very hard because there's so many arms to wound care. If I had to start over again, I've been doing this 28 years. If I had to start over again, I would be lost because there's so much to it. So when it comes to selecting modalities, even dressings, I based it all on the wound characteristics. And I kind of simplify it by using the phases of healing or the different phases. So if we look at the inflammatory phase, the wound's you're gonna see redness, warmth, you're going to see inflammation, you may see infection. So there's certain modalities for that. So number one, if there's necrotic tissue, we have to get that out of there. So now we're able to utilize the modality for that. If the wound's infected, of course, we make our infection diagnosis based on the clinical signs and symptoms, but then we have to appropriately culture that bacteria so the doctor can prescribe antibiotics, but we can also assist with trying to make that bed better. So it's all based on the characteristics. Once you make it to the proliferative phase, now you can use different tools to get the wound to progress. So in a simplified, non-Southern answer, it's all based on the inflammatory phase.
So the key, like you're saying, is basically getting it to the point where you can actually get the wound to respond to the things you're doing.
Right. And knowing, knowing the characteristics for each phase of healing, because the common problem throughout the wound care field is that we start applying, and actually I've written articles about this, is that we try to get to the advanced and we forget the basics. So without the basics, we're not going to progress that wound and we're just wasting money.
Which goes back to the fact that you really do need some specialized training in this area because we just don't get it in school. By the way, Frank, you mentioned something. You've been a therapist for 28 years. So have I. So we must have graduated 1991 for you?
Yes, sir.
Okay.
Oh, yeah.
Wow. How about that? I did not plan that, folks. That just happened. So
I didn't either, but I'm glad that we both still look young.
Oh, yeah. Well, you don't see my hair fully. It's a bit more gray than yours. So, but I've got 12 kids, so that makes me prematurely gray.
Yeah, more power to you.
Thanks. Hey, so I wanted to ask you, you mentioned, using modalities and interventions. Is hydrotherapy or the use of whirlpools, is that dead in wound care, or is there still an application for that?
Well, I think over time the usage has decreased, but because it is a form of mechanical debridement, some people may still utilize it in the U.S. Now, lately, it's used more for removing necrotic debris and contamination. So it's been used to kind of cleanse the area. But if you go back in history, hydrotherapy started on burn patients. So, there's a limited use, but you also have to realize that the other camp on the other side is saying they don't use it anymore because there's a chance of higher cross-contamination. Also, you have to keep the extremity for 20 minutes at least. So there's a chance that you're not helping edema. Okay. And then sometimes, depending, if you have good healthy tissue, it could destroy that because you put it in an area where you're agitating it and you may be adding chemicals to it.
Right.
So it's got a place, but I don't see it used as often just because we have all this evidence-based practices out there saying that we have other things that could help the wound faster.
Yeah, and I agree, and I have some experience in wound care myself, and we even the few years ago when I was doing it, we really were trending, far away from using Whirlpool, partly because of the concern, like you said, of cross contamination, and you've got these patients that are very medically complex, so for them to get an infection can be very deadly for them.
Right. Right.
Now, there's one thing that I talk a lot about in my documentation course that you've alluded to, and that is the specific measurements that really any therapist that's addressing wounds should be taking. What are some of the key measurements that you're looking at that you need to objectify to prove that you're necessary?
All right. Well, let me add something to that. When I trained in therapy, what I was told was, before I meet the patient, I should pick up their chart and read the record and get a mental picture of what that wound looks like. And a lot of times when I go reviewing charts at different facilities, they usually ask me to review the wound care program. And sometimes I can't even imagine what the wound looks like because the documentation is not well written. So everything about the wound characteristics will tell me if the wound's progressing or not and how I should treat it. So, to make sure, I have a couple of things in my head right now, but ask me the question again. I apologize.
Oh, that's fine. That's fine.
Sure.
Yeah, so I was just saying,
sure
what are some of the minimal things you want a therapist to be measuring that tell you exactly what you need to know about the wound?
Okay. Now, so to answer that properly, when I look at wounds, I usually think of 15 different categories in my head. Okay. So when you ask me the minimum, to me, that's going to be hard because I need all of those 15 things to give me an answer. Okay. So I will go through them real quick with you.
Sure.
But it typically, those 15 things will tell me what the inside of the wound looks like and also what the outside of the wound looks like. And when I combine those two things, it will tell me not only what kind of wound it is, but what I need to do next. So when you look at, you need to know the location because the location can differentiate what type of wound. You also need to know what's causing it. Okay? Typically, a doctor will say, here's a wound, I want you to compress them. The diagnosis may be swelling, but you have to go back and do due diligence because if that wound has an arterial component to that venous component and you put compression, you're going to harm the patient. So location, the cause, the size, the depth, the drainage, and by drainage, what type and how much. Okay? The color of the wound bed. I want to know also, is there undermining? Is there tracks? Is there tunnels? I want to look at the outside of the skin. Is there redness? Is there hardness or induration? Is there maceration? Is there warmth? Is there swelling? Do they have sensation? When you start compiling all those things, an odor, it will tell you, is the wound infected? Is it inflamed? Do you have healthy tissue? Is the type of the tissue, is it red or is it healthy red? So when I consult, I have to ask those questions because if they don't know those answers, then I'm not going to be of help. So anyway, so to simplify it, I still, there's 15 things it's what's important.
Right. And you bring up such a good point that you talked about things like anatomy, like knowing the location and determining the wound characteristics, and that tells you what kind of wound it is. That's getting into skill. And one of the things I talk about in my documentation course is the fact that, more measurement that takes knowledge demonstrates skill. And that's what we're getting paid for. And so all of that you just talked about really is demonstration of knowledge that should be on paper. Now, can you give me an example, and just maybe one example of what might be a sample goal that you as a therapist will have for a patient that has a wound? Like, how would you write a goal related to wound
Okay.
care?
Well, if you didn't assess it, document it, then you can't objectively write a goal. So that's why the size, the amount of necrotic tissue and all that is important. Because now I can look at different aspects. So it may be that I want to decrease the swelling. So now I have measurements. Okay? It may be that I want to decrease the necrotic or non-viable tissue by a certain amount. It may be that I want to decrease the depth, the size. So when I write goals, I base on what do I see that can use my skill, and then I go by determining a decrease in number. So the other thing I want to add to that, and I know I'm being very general, but I mean, it could be, to answer that, it could be decrease size of the wound by so much, or decrease necrotic tissue by this much. But also you have to consider that there's other goals that are not wound care related that I will write. So if I'm having to, if I determine that the cause of the wound is neuropathy, it's going to be that I'm going to have to offload that patient. So now I need to write a goal on how am I going to safely make sure the patient doesn't put weight over the wound. So it may be that I have to educate them on walking with a rolling walker, you know, so many feet. And the last thing is educating them, the patient and the family. I typically throw those in there because that's important for me.
Very good. And Frank, you're actually hitting everything out of the ballpark here. And it relates to something I teach in my course, that we basically have three focuses of our treatment: improving impairments, compensating for impairments, and environmental adaptations. And so we directly try to heal the wound, or provide the environment for it to heal. We teach them to compensate for the functional deficits related to the wound. And then we teach environmentally, we teach things that can be done, like caregiver education, to offload the wound so it has that good environment. So, we didn't even talk beforehand about that. And you just bang, 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 hit all those things. So I appreciate it. Now, let me ask you something. You talk about collaboration with nursing. How does when you're working hand in hand with the nurse, one of the things that Medicare looks at is duplication of services. They want to make sure we're not doing the same thing at the same time. Describe in brief, how do you collaborate with the nurse and make sure that it's clear you're doing something separate from the nurse?
Yes, and that's usually the hardest thing for people to realize. Number one, to realize that we can work together. Number two, you have to be specific, because we have to work on our own plan of care, and the nurses may have to work on their own plan of care by the physician-driven. So pretty much I see there's many places out there across the U.S. that they work well together, but they have their own plan of care. Now, their roles are determined a little differently too. But, you know, there's some things that we can overlap in, but we just have to make sure that we are following our practice acts. So there's some models out there that try to work under one practice act or one scope of practice. Kind of gray. I wouldn't, you know, but I'm not well versed in that, so I can't talk about it. But I know that it may be that in a hospital setting, it may be that the nurses get involved with this aspect of it, and then they ask the therapist to come in and debride. And it could be that when they finish, they can apply negative pressure when they're finished. Even though that nursing is capable of doing negative pressure wound therapy, they can utilize a team approach by having therapists debride, because we know that wounds that have good blood flow, that the more that we provide maintenance debridement, that they heal faster.
Right. You know, you bring up a good point about working together and making sure you're not overlapping. And then you talked about scope of practice a little bit. It's important to know your state practice act, to know Medicare's Practice Act, which generally is what we call national coverage determinations and local coverage determinations. And then, of course, if you're working together, while you might have overlapping in your scopes, do make sure in your documentation it's clear you're doing separate and distinct services, because otherwise you might not get paid. So I'm glad you hit on all that.
And it could be that they're dealing with one wound that's on the right track, and it could be that we're dealing with another wound and we're having to use modalities to tag whatever the problem we're dealing with.
Right, because each wound might have a different etiology that needs to be addressed differently, or a different stage of healing that won't respond to certain things that you're doing with the other wound. Now, can you describe briefly, Frank, what is billable as a service for wound care, and maybe what's not billable?
Yes, and actually that, I think that's where a lot of therapists struggle with the billable part. I think that we're great with what we do, but we haven't had a lot of training on the billable component. But typically, I kind of simplified in my head. Typically, we have to do an assessment. Okay. From there on, we start treating. But the way I look at charges is where it's changed over the years so much. Well, now if you still use hydrotherapy, you still have a CPT code for that. Then now you also have a wound care active treatment, which is based on whether you're debriding selectively or non-selective. And by that I mean non-selective. It could be the use of an enzymatic debrider, the use of a mechanical debrider. And then you have the selective, which now you're using a scalpel, scissors, forceps. Okay? Now, I'm not the expert on billing, but I can tell you that usually those codes are in the 9-7, whereas the debridement that starts with 11s, that's for your physician, because they're going outside of the margin of that wound, and a therapist cannot debride into healthy tissue. So
right.
we only remove non-viable. So you have the active wound care part, and then you have the negative pressure billing codes. And now the way I break it down is based on size, whether it's 50 centimeters or less, 50 centimeters greater. And then is it one that is battery operated, you plug to the wall, or is it one that's mechanical or now use suction, gravity assisted? But regardless, the hard thing for therapists is that when we bill, it includes let's say we have a wound that's less than 20 centimeters squared. Well, we use the active wound care code, but then we have to include the dressing. It's all bundled into that charge. And correct me if I'm wrong, but nowadays when you start using a lot of dressings, it could be quite expensive since it's all bundled into one part. So, but I'm not the wound care billing expert, but I know that you have to follow those, and your documentation needs to meet what you're doing.
Right. You talk about the bundling of the billing can really impact what you're capable of doing if you want to remain in business, obviously, because your boss won't be too happy if you're causing too much loss with your wound care. So we do have to be somewhat judicious in how we apply these techniques and the equipment that we need for doing wound care. Well, Frank, you proved probably with even just half your brain tied behind your back that you really know a lot about wound care. How can those that are watching this video today get in touch with you in the future if they want to learn more about wound care or getting certified or things like that?
Well, the best way is to email me. We're in exciting times. There's a lot of movement, a lot of education. If they want to learn more, they can email me at frank.aviles, spelled A-V as in Victor, I-L-E-S as in Sam, at N as in Nancy, R M as in Mary, C as in Charlie, hospital.org. So if they
Great.
want to email me there, I usually answer at night or early in the morning. So I would be happy.
Whenever you're not getting your very limited sleep time in.
Well, John, I'm trying to change that. I was asked to write an article about things affecting wound healing, including oxygen. So I did an article on how oxygen, being oxygen deprived or having obstructive sleep apnea can hurt the healing of wounds. And that I'm trying to change my ways, but I'm having a hard time.
And you probably already know this, but chronic sleep deprivation has been shown to lead to possibly diabetes type 2. And so that can cause problems with wound development too. So here I am lecturing Frank on making sure he gets more sleep.
Oh,
well, thank you so much. Go
You're
ahead.
welcome.
So
I like what I do, and I appreciate you having me here. And anything I can do to help, I'm here.
All right. Well, Frank Aviles, PT extraordinaire, thanks so much. And this is John Adamson, the rehab and documentation guru, reminding you to get paid for what you do. Take care and God bless. And I got to turn this off. There we go. Oh, wait a minute.